All right. Dr. Gish here online. How's everybody?
Good. How are you doing?
Good, thanks.
All right. People ready to dig into a talk on drug-induced liver disease?
Yeah.
All right.
Let's do it.
Me get this set up. This is quite a long presentation. Some of the things I am going to move through quite quickly, but I'll send this deck for everybody to share because there's a lot of key information that's really going to be good for, say, studying for boards. Okay.
Great. Thank you.
Everything you want to know. Oh, let's back up. Okay. Are we ready to start? Are we waiting for anybody?
We can start. I think most of us are here. Dr. Ryan's here as well.
Okay. In the next 50 minutes, because I have another call I have to set up for 6 o'clock, so I'm going to be done about 5:50, if that's okay with everybody. We are going to talk about drug-induced liver disease, and I'm going to tell you that one of the biggest mistakes I've seen, mostly in medical legal cases, but also in a criminal case I was involved with, they blamed a drug, they blamed an herb, blamed a medication, but the workup was incredibly incomplete. They said, oh, this person took this med, they're in liver failure, has to be the medication. Well, clinical acumen may be good, that may be all right in the hospital or ICU, where you, but again, you don't want to miss something that's treatable, such as a viral infection. But once it gets into a court of law, it's just so easy to shoot down these plaintiff cases when the doctors did a very incomplete workup. So I think for great patient care, you need to do a workup. And I just put this checklist up. There's even more. But some of the things that people miss are CMV, Epstein-Barr virus, which can cause acute liver injury and acute liver failure, missing Wilson disease, which actually is not on this list, a ceruloplasmin. It can be missed. It's important to have that test to be complete. Autoimmune workup, hepatitis E, which we do see in the United States, a complete viral hepatitis workup and panel, including RNA PCR. Serology for these viruses and acute liver disease are really poor, high false negative rate. So if you want to do this complete workup, you get a PCR for B, for C. Hepatitis E, IgM is probably okay. PCR for CMV, Epstein-Barr, and herpes are very important. So I can send you a more complete checklist, but I just put this slide up here for this important talking point. All right, so there are some clinical practice guidelines that I'm going to go through, but really we're going to talk here about mechanism, histology, biotransformation, genomics, understand drug metabolism, understand the immune system and hypersensitivity. There's a whole spectrum of issues, but you can see on the right side total drug-related side effects in terms of numbers since 2004. Why this increase has taken place, partially it has to do with reporting has gotten much, much better, but definitely there's a lot more medications on the market, each of which have some risk of acute liver injury. And I'm going to talk about how the FDA abrogates that. Next few slides are just how people go through a PICO and grading and recommendations. So I'm going to skip through these slides pretty quickly after I just talk about this general what we call phenotype of liver injury. Of course, everybody knows about fatty liver, viral hepatitis, necrosis. This happens to be from syncope, hypotension, cardiac arrest. You have to think about cholestatic patterns. Are they hepatitic blend or just bland cholestasis? There are other injuries that can take place, including sinusoidal obstructive syndrome, Budd-Chiari syndrome, acute portal vein thrombosis, and of course, immune modulations. And of course, we've mentioned some other things like liver masses that are here. The next is this Oxford Center for Evidence-Based Medicine, about how they come up with guidelines as opposed to guidance, and how they work through these. So these are all for studying for your boards, just what you need to think about, or you can use for reference when you're reviewing guidelines. So we're now going to move back into the drug-induced process. So you have a medication, events take place, whether they're immune or metabolic, and you have these reactive metabolites, changes in drug elimination, covalent binding, hapten, oxidative stress, mitochondrial injury, endoplasmic reticulum stress, and cell death can take place through autophagy, apoptosis, necrosis, and a variety of other signaling pathways. Drug properties, one of the most important rule about drug-induced liver disease is the risk is much higher when you get above 500 milligrams for a dose of a medication, such as we see with amoxicillin, or more commonly with Augmentin, nitrofurantoin. There's a number of medicines that once you get up into the gram range, you have a much higher risk of liver toxicity. On the right side, we have these host factors. We will be profiling our patients eventually with genetics. You're going to come in to see your primary care provider. They're going to do a genetic profile, and they're going to tell you which drugs not to take. That is available now, but it's on a limited basis. Insurance companies usually don't pay for it. And there's other issues such as nutrition, malnutrition, alcohol, level of alcohol intake, smoking exposure, which can induce different types of what are called MEOS, or part of the endoplasmic reticulum. Medication interactions, what's going on in the gut, including gut flora, which we don't fully understand. So this gets pretty complicated. So population-based studies talk about how many cases per 100,000 inhabitants per year. So you can say, oh, this isn't that common. But of course, if you're on a GI or liver service, it's going to be part of your practice each month. The 2.7 in the US, I think, is a low estimate because these are reports through gastroenterology practices. There's a number of prospective registries. The Spanish one is great, the DILI network in the United States, and there's a Latin DILI network that's quite good also, but this is a bias towards severe hospitalized patients. Gives you a little bit more information here about what's the worst in Spain, USA, Latin America, Iceland. 3 out of 4, it's antibiotics. In Latin America, it's NSAIDs, probably because they're treating chronic pain. Anti-infectives are slight behind. When it says anti-androgens, I'm going to put down it's probably both pro and anti-androgens, but I think in this case, maybe drugs like tamoxifen that might be listed here. USA, we have a lot of anti-neoplastic drugs that are available that aren't available in other parts of the world or aren't used as much due to cost. So these are very, very important points. Again, this has to do with qualification of liver injury, and you look at ALT and your report, is it 5 times, 3 times, 2 times the upper limits of normal? And of course, the bottom one in that qualification is Hy's Law, ALT 3 times, total bilirubin greater than 2 times upper limits of normal. And then you have this R value where you look at ALT and the ratio to alkaline phosphatase. So an R value is very important to calculate to say, is it hepatocellular, cholestatic, or mixed? And that helps you decide which pathway you want to go down when you have your differential for which antibiotic, because a lot of our patients are on 2 or 3 or 4 medications, each of which could have some relative risk of liver injury. Hy's Law, super important. What's the sensitivity of Hy's Law? Hyman Zimmerman is the one that came up with this sensitivity. I actually met Hyman, and I remember being at Robert Perillo's house in Dallas playing with model trains with my kids, actually, when Hyman Zimmerman was still active, although semi-retired from where I think he worked at the Naval Institute in Washington, D.C. at the time. There's a modification of Hy's Law through the Spanish DILI registry, which is a little bit different here, and you can see about sensitivity and specificity. The idea here is to come up with a lower false positive rate or higher specificity, of course, and get to a higher level of accuracy like the AROC. So that new Hy's Law on the far right may be a little bit better. And this has to do with the fact that when you're talking about liver injury and potentially fatal liver injury, this is typically driven by a hepatocellular pattern, not a cholestatic pattern. Let's see, pretty much the same, just a little bit more data. And FDA has their own definition. They're using this ALT bilirubin that we talked for. And why wait for jaundice? No, you watch that bilirubin, you check that bilirubin, anything over 2, and you've got a problem that is present here. This is that pyramid about safety, ALT alone with normal bilirubin, and boom, you get to the very top of that when you get that bilirubin signal in terms of mortality rate. Drugs that are capable of causing acute liver failure will cause more frequent ALT elevations greater than 3 times the upper limits of normal. But again, this moves in parallel with bilirubin. We are talking about the potential of death, potential of liver transplant. So if a drug does not cause ALT elevation, it's purely cholestatic, high ALT phos plus a bilirubin, high GGT plus a bilirubin, very unlikely that patient will end up in the hospital, transplant, or dying. That ALT really helps guide you. So this E-DISH format, I look at all the time, every month in different programs I'm looking at. I'm on 3 different DSMBs right now. Actually, I'm chairing 3 DSMBs, and I'm on 2 other DSMBs. And I'll be adding another DSMB first. So I'm really getting into safety. So knowing this E-DISH grid is super important. And it's the upper right-hand corner where you're talking about that ALT and bilirubin, and that 2x bilirubin is absolutely key here. So once these patients have this ALT total bilirubin signal, this is going to be a flag for the FDA in terms of drug approval. OCA was recently in front of the FDA for the 2nd time to be approved for fatty liver disease. And fatty liver disease is super common. We have no drugs that are FDA approved for fatty liver disease. They met their endpoint by improving fibrosis, reversing fibrosis, predetermined endpoint the FDA had agreed to. And the FDA 2nd time turned them down because there was a signal of liver toxicity in that clinical trial, even the extended clinical trial. Although I think there were only 2 cases, they extrapolated those 2 cases to a population of maybe 5 or 10 million people. And they calculated there may be up to 60 patients who developed liver failure from OCA. And they said that the benefits did not outweigh these liver risks. That was the response from the FDA, both advisory panel and ultimately in their letter, complete response letter they got. So the FDA is super conservative, especially when you have a chronic disease that's going to be like fatty liver that might be useful. And here they have this grade of evidence and grade of recommendation. This is super important that are here. Laboratory workup, you can see a very important issue here is hepatitis C workup by PCR, hepatitis E workup preferably by PCR, but IgM is useful. And I really mentioned a much broader number of tests I think you should do in these patients on a serologic and also on a molecular basis. Ultrasound, Doppler, every patient looking for Budd-Chiari syndrome, looking for acute portal vein thrombosis. Liver biopsy in a selected population, that's really case by case if you're confused, especially if you think there may be an autoimmune component. That autoimmune component can be treated with steroids and immune suppression. Of course, you can manage that. And there are some drug-induced liver disease that result in autoimmune liver disease or an autoimmune-like liver disease, such as checkpoint inhibitors. Again, biopsy can be useful to determine the actual diagnosis and whether it justifies going into an immune suppression protocol of some type. All right, causality, there's something called COMS, which I'm not going to expect that you would do in your practice, but the COMS has a specific grading or systematic way to look at laboratory tests and give you a score probability. That's much more for publications, that's much more for medical legal cases, but you should know about it. It might be on a board test. Rechallenge is not advocated unless there's absolutely something critical like an anti-seizure drug or anti-arrhythmic. That is very, very important for that patient's care. So rechallenge gives you a lot of information, but not necessarily directly beneficial to the patient. So genetic testing is available. Again, this is what I would do today is if I had a setting where I'm choosing between one great drug and one not so great drug, and the great drug has data in the literature about some type of genetic profile that result in a much higher risk of liver toxicity. and these are commercially available. Sometimes you have to be dealing with an expert, a geneticist, in interpreting the results, but I think they're quite useful in very selected cases. Fluoroquinolones is not something that's very commonly used, and I don't know if it's even available in the US anymore, but there's an HLA genotype that was directly associated with a substantially higher risk. And look at the odds ratio here of 80 to 100. That's gigantic if you had this HLA-B 5701. Another GWAS HLA association for augmentin. This is a very common antibiotic used and also very commonly associated with acute liver injury, including fulminant liver failure and transplant. So you've got these polymorphisms that are present that can definitely identify these high-risk individuals. The whole list of other drugs here with different proportionalities up to, say, if you're in the 2 to 5 range, it's kind of interesting because augmentin just has a 2.3 to 2.8, but it's used so commonly that we see this in practice. There's some other drugs here, which I can't even pronounce the names of these, which I think are low risk that aren't very commonly used. Gatran has got to be one of the DOACs, but I haven't even seen a patient on that. Minocycline, that's used a lot by dermatologists, used for a variety of other infections. Cyclodipine also, as I recall, being used by cardiologists. What's interesting on here to me, and the most important drug on here, is fenofibrate. We are planning to be using fenofibrate a lot more, pending bezafibrate approval for PBC in the US. Right now in Europe, if you have PBC or PSC, it's very likely you're going to be on a fibrate as first-line therapy. I didn't really talk on our PSC lecture, I think, before about that, but we'll make sure we bring that up again. Terbinafine, pretty high risk here, pretty commonly used, as I recall, for allergies. So a lot of genetic variants is something that you will see on boards most likely. It's not ready for prime time in your practice unless you're faced with a specific question. It's more likely something that would come up on a primary care or infectious disease doctor or maybe cardiologist or neurologist for seizure disorders. But there are definitely genetic predispositions to drug-induced liver disease, no doubt about it. Okay, you have high liver tests. High biochemistries, acute hepatitis picture. Are you going to look for other issues? You're going to look for toxic etiology that might run in parallel, skin, kidney issues. You're going to take over-the-counter drug history, supplements, bodybuilding medications, and both about what they're taking now, but anything that's been added or changed in the last 6 months is my rule of thumb. Patients are poor historians. You may need to get a pharmacy record, but there's always pharmacy records for these prescription medicines, but very difficult for over-the-counter. So you want the patient or family to bring in receipts or pictures or actually bring in the bottles of something that they may be consuming or taking at home. Super important to take that history. We already talked about this pattern, this R pattern, that's super important. That should be in your consult notes if you're seeing a patient where you think it's DILI. You can see this expanded list down below. Still does not include herpes, but I have seen severe acute herpes-induced liver disease in my career. For alcohol, you're going to take a history, but more importantly, you're going to order PEth testing, P-E-T-H. You're going to get a Doppler ultrasound looking for hepatic ischemia, clots, congestion. Do a cardiac workup at a very low threshold, which would be an EKG and cardiac echo. Antibody titers are important, nuclear antibodies, smooth muscle, quantitative immune globulins. The ultrasound is going to answer what's going on in the liver, including the biliary system. I would say moderate to high threshold to do a biopsy, but a biopsy should be done if you think there's something that is treatable. There's some other issue about cholestyramine. I've never used that before. Carnitine, yes, if you have valproate-induced hepatotoxicity, which can present with extremely high ammonia levels. Valproic acid inhibits the urea cycle, believe it or not. NAC is really most useful for, of course, acetaminophen-induced liver injury, but there is some data, including alcohol, acute on chronic, and fulminant liver failure, that NAC is useful. I think it's very cheap, especially if you use the oral form of NAC. I have a low threshold to use that. Urso, I only use in cholestatic liver injury. You're not going to find that useful in acute liver injury that's AST or ALT dominant. Liver transplantation, you're going to follow the general rules. MELD over 15, you're going to call a transplant center. And of course, NAC here, they're advising an idiosyncratic drug-induced acute liver failure. Steroids has not been substantiated unless you have biopsy documented picture of autoimmune hepatitis. That's my advice and my interpretation. Monitoring with liver tests, Hy's Law are all covered here. Causality, genetic testing are all addressed. Important thing on this is the whole issue about checkpoint inhibitors. We've got CTLA-4, including ipilimumab, that's approved for liver cancer. You've got nivolumab. You've got other new drugs. Durvalumab was just approved for HCC in combination with tremelimumab, and tezolizumab approved for HCC in combination with the VEGF inhibitor. And these are being used for a variety of cancers, including lung cancer, melanoma as examples, where these immunomodulators are super useful, super important. This just talks about checkpoint inhibitor toxicity, where you may see elevated liver tests in combination with a variety of other autoimmune profile. A little higher with PD-1 enzymes as opposed to anti-PD-L1. And I always have to look up which drug is doing which. Toxicity management really goes with steroids or steroids plus mycophenolate. But this is something you need to know about, follow protocol. There's a lot of details behind how to do this. We're going to cover checkpoint, more on checkpoint inhibitors. I'm going to move through some of this quickly that you can look at in the past. Let's see, combinations the worst. So if you have a CTLA-4 and an anti-PD-1 or PD-L1, such as the DT therapy I just mentioned for liver cancer, that risk of liver toxicity is definitely higher, maybe 1 in 10, 1 in 12 people. I'm going to keep moving through this. There's just a little bit more on checkpoint inhibitor there. Biliary strictures, again, you're going to evaluate that with an ultrasound, MRCP if you're really concerned. Something is showing biliary obstruction, cancer, stone, otherwise you're going to do an ERCP. This is again to rule out other diseases that may be making you think about drug-induced liver disease. Granulomatous liver disease, if you suspect that, it's going to require a biopsy. Imaging on MR, CT, or ultrasound may show sort of a starry sky in the liver. And of course, these patients typically have high ALT phos and GGT as well as high liver enzymes. Let's see, fatty liver, you can see from different drugs. I mentioned valproic acid with fatty liver plus hyperammonemia. That's one of the classics that are in this case. Aspirin in children, of course, with the Rise-like syndrome. Amiodarone, methotrexate, tamoxifen, all associated with a fatty liver picture, but also can be really seen with marked elevated liver enzymes, including bilirubin. I've seen 5-FU listed, irinotecan listed. I've never seen that in my practice, except one 5-FU case. Another form of drug-induced liver disease is nodular regenerative hyperplasia, NRH. Most common, I think of this, that we'd see in hepatology and GI is anti-metabolites, such as Imuran or 6-MP. It's also been reported with mycophenolate, but there's some other medications that you can look at that are NRH associated. A little bit more here, oral contraceptives associated with the development of liver tumors, specifically adenomas, androgens, androgenic steroids, may be used to treat bone marrow failure, but also people who are doing bodybuilding can cause cholestatic liver injury and also are associated with a variety of different liver tumors. So this is a very complex slide. I'm not going to expect you to memorize this, but this is what research is going on in terms of biomarkers for drug-induced liver disease. Some of these biomarkers have to do with just cytokine modulation and immune cell activation, but others are signs of mitochondrial toxicity, such as GLD. I think that's glutamic acid. I don't remember what GLD stands for, but it's an example The rest of these are basically markers of liver injury as opposed to directly telling you which drug is involved. But if you have acute liver injury and you're seeing some of these patterns, at least in a research setting, it might point to drug-induced liver disease as opposed to autoimmune or a viral cause. These are liver safety biomarkers. The EMEA or FDA have talked about for exploratory use and clinical drug development. I'm involved with a lot of drug development. I've never seen any of these biomarkers directly used in terms of drug safety or drug risk prediction. So in research, we'll say at the best. Let's see. There are challenges going on with socioeconomic status in this country in terms of having higher risk of liver disease, such as fatty liver disease. If you have fatty liver disease, you're higher risk of drug-induced liver disease. Fatty liver disease is a well-known associate of mitochondrial injury. You have mitochondrial injury, you're at high risk of other forms of drug-induced liver disease where mitochondrial metabolism is important. It's definitely the case with drugs historically that are nucleoside or nucleotide analogs used for antiviral treatment. There was a drug used or in development for hepatitis B called FIAU, F-I-A-U. I know all the details of this because I almost did research on the drug, and I'm glad that Lilly bought the drug and then NIH basically scooped the use of the drug. So they wanted to be first in line to show that this worked for hepatitis B, and they had 5 patients develop total body acidosis, pancreatitis, liver failure. I think all of them died. One went to transplant, but I think also died. It was a giant scandal for a time, sad scandal. What's the ratio of people with cholestasis versus a hepatic pattern or mixed pattern? Up to 50% of patients have a cholestatic component, so either mixed or classic pure cholestatic type pattern. You can look down at the bottom. It's kind of interesting because what's listed here is the different forms of heparin, including long-acting heparins. I've only seen one case in my career, but it was a large number of cases in this a database. And I think this is the Spanish DILI, or this is reported. Antibacterial, tuberculosis, antimycotics such as ketoconazole that had definite association with liver injury, antivirals, we've mentioned, anti-cancer, another big spike that are here. There's a number of NSAIDs on the market that cause liver injury that have been pulled off the market. Our current risk of our current NSAIDs, such as ibuprofen, naproxen, causing liver injury is about 1 in 80,000. The report on here on statin-induced liver injury is probably not correct. We now know that the risk of statin-induced liver injury from a number of large databases is also 1 in 80,000 people. But statins get blamed because of the history black box that statins had on them. So we've moved from statins being liver toxic, that's wrong, to neutral, and now we're using statins as liver protective. And of course, you see an herbal spike on here too. This is just talking about drug metabolism, the drug being toxic directly, or the metabolic product being toxic, or a hapten of the metabolic product being toxic, but also turning on an immune response. That's also partially direct toxicity, but once you have that, you may have a secondary immune response as well. Let's see, acetaminophen, take it by mouth, hepatic metabolism, generation of these reactive oxygen species, ROS, versus detox by conjugation. You have all these issues about absorption, distribution, metabolism, and that's why with acetaminophen, we are very, very clear that we think there's no risk at 2 grams per day or less. The only time, even between 2 and 4 grams per day, that I consider it an issue is if you have a malnourished alcoholic patient, alcohol use disorder, consuming alcohol currently, which shifts a variety of different steps in the liver in terms of drug metabolism. So we do know this APAP pathway, there's issue about this NAPQI forming these reactive species. And if you run out of glutathione, you run out of these sulfhydryl groups, you have these reactive oxygen species that are attached to this benzyl group, and you get liver toxicity. There's other pathways for acetaminophen, but they're minor pathways. And if you overwhelm that with a large amount of acetaminophen, you will get liver injury. So phase 1, phase 2, you might be asked these questions on the board. Hydroxylation, cytochrome P450. Phase 2 is conjugation to sulfate, glucuronide, or glutathione. That'll just be pretty simple. You got the biliary export phase. You have also the possibility of moving the drug or metabolite back into systemic circulation. This would be phase 4, although I think that's relatively rare. Let's see, pharmacogenomics. I think we've talked about this. This just talks about the different phases of metabolites, and I think we've covered that. Modification of functional, this is just a list of all the different cytochrome. Actually, I was at an ad board in Vienna last week, and there was a specific medication that we were talking about who had a specific metabolic pathway with, I think it was a CYP2C8 is listed on here, relatively rare. I talked to another person yesterday doing a phone consult about another drug development. And I said, look, if you're going to develop this drug, you really need to do genetic sequencing in your patients, because the risk of cholestatic liver injury from this drug in a recent trial was about 8 to 10%. I said, you can risk manage this up front. You just do genetic testing and don't put these people in your trial if they have one of these cholestatic gene defects that you might see with PFIC1, PFIC2, PFIC3, et cetera. Those are called ABC transporters, and there's a whole group of them that you'll probably need to study for your boards. I don't think we're going to go over that today. Conjugations listed here: glutathione transferases, or thiopurine methyltransferase deficiency, TPMT, which you all know about because you test for that before you put a patient on Imuran or 6-MP because of this risk of fatal bone marrow toxicity. I have never seen that in a liver patient, although I've used Imuran in the past, of course, for treating autoimmune liver disease. I do measure this sometimes, but it's more random than mandated, although I'm doing it more now because it's advised to have it done in the guidelines. And if you don't do it and you have liver injury, you're probably a setup for legal action. Idiosyncratic means we don't know what's going on, but we probably will know what's going on with genetic sequencing and population studies, drug reporting studies that are there. And it may be a combination of metabolic steps, immune activation, or potentially both. So if you have DILI, there's an adaptive immune response more than an innate immune system that seems to be involved. If it's idiosyncratic, it does appear to be immune. So we might take away that idiosyncratic eventually. Interaction between HLA genotypes and T cell receptors. The adaptive immune response does require an innate response to activate the antigen presenting cells, but it's a two-step process. The innate immune response is not idiosyncratic and can easily be studied in humans. So very important to be thinking about this. Okay, let's go down a little bit more. We have this HLA B3501 green tea induced liver injury. Definitely had a couple of cases of this in my career. Look at on the right side, it really goes through all these different dietary supplement cases. There's an adjudicated process that takes place as well. And green tea was judged to be, in 40 cases, to be highly likely or probable. So this is something, and it's green tea extract typically. A little bit more on Hoofnagel. Let's see, is there anything important on here? Rash, 13%. Let's see, multi-ingredient supplements, 80%. That makes this really complicated. Bilirubin went to 7, peak 13. Half these patients had autoantibodies, which is quite interesting. This is definitely a hepatocellular pattern, 95%. Severe in a third, moderate in half. So this is pretty toxic. And again, green tea extract is the most important thing to remember. Just talking about that. Let's see. Oh, very important part of this slide is using the Liver Tox website. You can look up medications, herbs, or supplements here. I find this extremely useful, valuable, credible, although sometimes they miss a couple of big picture issues that we talked about, is making sure you get your whole panel of tests that are done to make sure you aren't missing something such as Wilson disease or weird virus of some type, including adenovirus. So that's got to be on my current list after those 30, 40 cases over the last 3 years that were reported during the pandemic that ended up being highly likely to be adeno, although it's much more of a pediatric issue than an adult issue. Let's see, acute, chronic, acute, we covered everything here. Oh, one thing to highlight on this slide is the granulomatous with phenytoin. That's still fairly common to be used for seizures, and allopurinol being used for gout. I really like to get biopsies to document this because it really allows you to justify back to the neurologist switching to gabapentin or something else, or they've got gout, some other way to modify their gout. Another thing on this slide is this acute and chronic cholestasis is with androgens. There's a huge amount of androgen supplements being taken by especially men who are involved in bodybuilding. And these androgens are actually plant-derived, and they're also what are called phytoestrogens, which have an androgenic property to them that's can be concentrated in these supplements. All right, let's see. We talked about most of the other drugs on here. Amiodarone was much more common when it was given IV as opposed to orally. And I think that's another point. Methotrexate, I think, is much over-exaggerated in terms of its risk of liver toxicity. I really see a big overlap in fatty liver patients or alcohol where this risk is amplified. In a thin person not drinking alcohol, I think the risk of methotrexate-induced liver injury is extremely low. Folic acid may decrease liver test abnormalities, but these patients do need to be monitored. That is the standard of care. Liver biopsies after 1, 3, and 8 grams of methotrexate, I think that's much less protocolized now. You're really going to individualize that on a patient basis. But if you have them on methotrexate and they have fatty liver and they're obese with diabetes, biopsy can be useful to tease out the cause of the liver injury. This is the methotrexate. Also looks like fatty liver, but you've got these interesting inflammatory cells that focus on some of the droplets. That's not really that typical for standard metabolic associated fatty liver disease. But the chicken wire fibrosis on the right, you can see that in alcohol, fatty liver, or methotrexate. This nuclear polymorphism may be seen with methotrexate, not seen in standard fatty liver. So there are some hints by biopsy that may be useful. Most commonly seen in psoriatic patients, very, very rare in patients with rheumatoid arthritis. Enzymes, grading. We already talked about acetaminophen, so there's some really good comments here. Biopsy tends to be this zone 3. Apparently that's where acetaminophen goes to. Glutathione levels are lower because there's lower oxygen in that area. So it's more of a central change as opposed to a portal change that you see here. You can have very high INRs with this, very similar to what you see with ischemic liver injury. So if you have a patient with acute liver injury, you always get a blood alcohol level, you always get a acetaminophen level, and now you always get a PET, PETH level, because that's going to tell you alcohol exposure back over the last 6 weeks. Super important. AST may go up higher than ALT, having to do with difference in clearance rates. These are all the different patterns that you can see in different patients. So it's really up to the patient to decide what their pattern is. 20 billion doses of acetaminophen. And yeah. Okay, so we talked about acetaminophen, central lobular, that looks like shock, that looks like hepatic ischemia. You might even see that with a new liver transplant, also with intravenous amiodarone, which is quite rare. And again, you're moving that liver enzymes, quickly moving INR super high. Bilirubin goes up much later, much slower. It's not typically part of the early pattern for these patients. Idiosyncratic we talked about, and we really think now that this isn't idiosyncratic, but it's immune related. And you can see all of these different medications up here, higher drugs. They said here 50 milligrams. I think 500 milligrams is a really solid cut point, but 50 milligrams is where you start seeing a higher risk. Again, 50 milligrams as the tablet dose. Let's see what else. Talk about phase 1, phase 2. Already gone all of that. Genetic, poorly covered most of this already. And aflatoxin, kind of an interesting point here. We don't really have a big problem with aflatoxin in our environment, except in peanut butter that's homemade or something like that, or eating kimchi. But there's a lot of aflatoxins in developing countries, tropical countries, Southeast Asia, including places like Korea, where they have a high kimchi production or consumption level. Aflatoxin then interacts with other drugs. Aflatoxin in and of itself is toxic and a pro-carcinogen. All right, covered all this. This is a very important history because we have pioglitazone on the market today, but a couple of other drugs that came out, troglitazone and rosiglitazone, were out on the market, caused liver toxicity, and had to be pulled from the market because signals weren't picked up early, or at least the FDA and the company didn't look at the early signals correctly. A lot of LDL release, again, just a cell toxicity marker, not specific. And just some other issues. Let's see, troglitazones. This is all history. But today you are using, well, your patients are using a lot of quinolones for different issues here. And of course, Cipro is the most common one that's being used today, as well as levofloxacin. But trovafloxacin, upper left corner, was put out on the market and caused a lot of liver toxicity and had to be pulled. Let's see, yeah, this is just showing here that Trova in that really super high curve in terms of liver toxicity risk. They could predict this, but here's levofloxacin with its antimicrobial and potential off target here. So the drug designers really do have a lot of data now on how to design a drug or how not to take a drug to market when it has a high risk profile. There are models, including stem cells, livers on a chip, other types of printer models of livers that people are using to test for drug toxicity. I just haven't seen anybody make one of these commercially viable, unfortunately. And of course, it's not just metabolism and drug injury. You need to have a model where you have both your innate and adaptive immune responses that probably is then going to be looking at the second wave of liver injury after a metabolic injury takes place. This is autoimmune liver disease. This is a case from nitrofurantoin and autoimmune mediated DILI. Markers, usually ANA has to be greater than 1 to 640, smooth muscle greater than 1 to 40, and IgG more than 1.2 times the upper limits of normal. But you start seeing these markers or eosinophilia, then you should be looking at doing a liver biopsy. I am going to stop because we have about 7 minutes left. I'm just going to click through a couple more slides here. There's a section on histology that's actually very, very interesting that I will send to you all. And it kind of repeats a lot of what we've gone over. There's a story here on obeticholic acid, including how it causes hyperlipidemia and issue about liver toxicity. And then finally, drug. And then there's an herbal section at the end. There's at least 40 different herbs that have been associated with drug-induced liver injury. You really have people bring in the bottles, bring in and look not just at the bottle and the label, but look at the components as part of that too. I've seen many of these drugs causing liver injury in my career. Germander I've seen. Jinbuwan was very popular 20 years ago. I saw that. Kava, which is still being consumed. I went to a Kava bar in San Diego recently, but nobody was jaundiced. Didn't hear any liver toxicity. So I don't know if there's a concentration induced issue. Kombucha is being sold everywhere. But again, this has to do with homemade issues, I believe, with combination. Got a lot of other ones on here. That's it. Weight loss, lipokinetics, mahuang, mate tea. They're selling it everywhere, but this was really seen with homemade preparations in the Caribbean, as opposed to the commercial ones that you might be able to get now. Comfrey was usually high concentration, like a comfrey oil. Ephedra, another one that's there. And Liver Tox website, Buddy Sussman, a variety of other people helped with this deck. And there's a little bit more in there, but I'm going to stop sharing and go to Q&A because I've got to get on another call in about 5 minutes. A lot to go through. I'll send you a link for this talk, of course.
Dr. Gage, sorry, go ahead. Go ahead.
Go for it. Go for it.
Ladies first. He has very little time. Go ahead.
Okay. So my question was, sometimes we see these concern for drug-induced liver injury patients in the hospital. We stop the offending agent. We kind of trend the labs to see if they improve. And sometimes they don't, or they're stagnant. And we've had some discussion about maybe considering doing biopsies at that time to see if there's like an autoimmune component to this as well. How long after you remove the concern of offending agent would you suggest that, or would you ever suggest that?
I do a biopsy only if I'm getting a signal with high immune globulins, autoantibody markers, eosinophilia. The chance of you finding an autoimmune component in drug-induced liver disease that's treatable with an immune suppressant is going to be about 5%. So be really selective before you think about that biopsy and you think about prednisone. These, liver injuries can last up to 6 months. They do not recover rapidly. Once you get a trend that bilirubin just starts dropping a little bit, the INR is dropping, they're not encephalopathic, they don't have ascites, their MELD's under 10, you can send them home provided that you've got good follow-up scheduled. If they're, housing unstable, no support, you're gonna need to keep them in the hospital a little bit longer to make sure that trend is there. And if you really feel like you have to do something, put them on URSO. If there's any mixed or cholestatic pattern, URSO seems to make people better more quickly, and it's inexpensive. Makes you feel good you're doing something.
Okay, thank you.
Kind of jumping off of her question, I guess it's a preempt. DILI is a diagnosis of exclusion, but about 70% of the time, let's say, we get a diagnosis just by getting good history. Do you still pursue the whole chronic liver disease type workup, or trying to rule out autoimmune and Wilson's and everything, or is that kind of just a medical legal type situation?
Every acute liver injury gets a Wilson workup. Every acute liver injury, you can do an autoimmune workup. You do an alcohol workup, blood alcohol and PET testing. You do a tox screen. You do an acetaminophen level, 100%. I've seen so many mistakes and bad care by people saying, oh, they said they weren't drinking, or they said they didn't take acetaminophen and they missed it. So this is standard of care. Still think when you don't know and you're just thinking it's an herb, you need to get those PCR tests I mentioned, BC, herpes, Epstein-Barr, and CMV. You're only talking about a couple $100 of testing. This is not, probably the entire test panel is $1,000. That's cheaper than 1 day in the hospital.
Got it. Thank you.